Bismillahirrahmanirrahim. Assalamu alaikum and good morning, everyone. I'm Dr. Maria Rauf, and I have joined Maroof Healthcare Services as Assistant Consultant Diagnostic and Interventional Radiology. The topic of my talk is breast cancer awareness and screening. As we all know, it's the month of October, and October is marked as Breast Cancer Awareness Month, and it is celebrated across worldwide. It helps to increase the attention and support for awareness, early detection, and treatment, as well as the palliative care regarding breast cancer. When we talk about breast cancer awareness, this campaign, it's basically an effort to raise awareness and reduce the stigma of breast cancer through education on symptoms and its treatment. The goal of this campaign is to raise the public awareness regarding breast cancer, its symptoms, its detection, and regarding its treatment. So we have to address all the queries regarding the breast cancer. As I said, October is celebrated as National Breast Cancer Awareness Month, and it was started back in 1985 when American Cancer Society collaborated with a local pharmaceutical company, and they launched this awareness campaign. And as a result of this campaign, the breast cancer were being detected at an earlier and more treatable stage. When we talk about breast cancer awareness, we talk about pink ribbon. Pink ribbon is basically the symbol which denotes the breast cancer awareness. It is associated with the individual generosity, the faith in scientific progress, and an optimistic can-do attitude to get awareness regarding the disease and to beat this disease. Definitely, when we talk about cancer awareness, there are certain myths which are prevalent in our society. We have to address those myths and we have to educate our population with facts. Some of the myths are as follows. I'm only 35. Breast cancer happens only in older women. This is the most common myth. While the fact is the risk of breast cancer, it increases with age. All women are at risk of getting breast cancer. Another myth that is believed in our society is women with family history of breast cancer are the ones who get breast cancer. Actually, the fact is most women who get breast cancer may not have any family history of the disease. Then it is also believed that women with more than one risk factor are the ones who typically get breast cancer, while majority of the women who are diagnosed with this disease have no known risk factors. And the last one is the most important one, as this is the question asked by almost every patient we came across. It is, if I had a mammogram every year, I would be exposed to too much radiation and that would cause cancer. However, the fact is the small level of radiation from annual mammograms, it is believed to be safe with benefits of early detection definitely outweighing the risk of radiation associated with it. So we have to address all these myths in our population and we have to educate them regarding these facts. Now we will have a quick look at breast cancer statistics worldwide and in Pakistan. It is believed that 1 in 9 women, they develop breast cancer in their lifetime. Breast cancer is the #1 diagnosed cancer in women. Males are also affected by this disease. However, prevalence is only about 0.6%. After lung cancer, breast is the second most common cancer in the terms of mortality rates. 1 in 3 women with breast cancer, they die of this disease, and it's quite a high death rate associated with any cancer. If we talk about Pakistan, Pakistan has one of the highest incidence rates in Asia. When we compare it with other Asian countries, the breast cancer rates are one of the highest in Pakistan. According to World Health Organization, the breast cancer rates are getting worse and it is not even sparing the younger age group. Now we are seeing this disease in younger population too. Women in developing countries like Pakistan, they tend to die at greater rates than of this disease than in more developed countries. This is because the disease is detected generally in advanced or later stages, and it is due to lack of proper awareness and starting the screening at earlier stage. Our population is not having these facilities, so the disease is detected at advanced stage, and that increases the mortality rates. The Pakistan statistics are 109 women die every 24 hours due to breast cancer in Pakistan. This makes approximately 40,000 deaths a year. And there is addition of 90,000 cases of breast cancer annually. Now we will just briefly talk about the signs and symptoms associated with breast carcinoma. The abnormal signs and symptoms of breast cancer, they include any skin puckering, skin dimpling, nipple retraction, any kind of nipple discharge, any kind of skin thickening, change in size of breast, any pain or any tenderness that is not going off, change in the nipple positions, scaling around the nipples, or the breast sores which do not heal. All women must be aware with all these signs and symptoms, and if they are experiencing any of these, immediate medical attention should be sought. Any change in your breast you see or feel does not mean it is a breast cancer. However, any change should be checked by a healthcare provider to exclude the possibility of breast cancer. This is an important point to understand. So we will talk about the causes. As the etiology behind most of the carcinomas, there were some of the cells in the breast region, they begin to grow abnormally. These divide at more rapid speed than healthy cells do and spread throughout the breast, forming a cancerous tumor. This is what most of the cancerous etiology is. Now, when we talk about the risk factors associated with breast carcinoma, they are grossly divided into modifiable risk factors and non-modifiable risk factors. If we see the modifiable risk factors, they are radiation exposure, obesity, diet, fats, alcohol consumptions, and etc. etc. These are modifiable. If we can reduce them, we can reduce the risk of breast cancer. However, some non-modifiable risk factors are also there and one cannot help with them. For example, female gender, increasing age, family history, history of late childbirth, and possibly some menstrual inconsistencies. How can we beat breast cancer? The answer is early detection is your best protection. What method of detection can we use to beat breast cancer or detect it as at an early stage? So the key to early detection is screening. If the breast cancer is found and treated early, the 5-year survival rate is about 95%. So I will say it again, the key to early detection is screening, and early detection is the key to beat breast cancer. American College of Radiology has provided us with some guidelines regarding the breast cancer screening for women at an average risk of developing breast cancer, and separately for the women who are at high risk of developing breast cancer. First, we will go through the guidelines for women at average risk of developing breast cancer. These guidelines say all women should have a risk assessment by the age of 30 to exclude that they are not in high risk category for developing breast cancer. If not in high risk category, then annual mammography screening should be starting at the age of 40 years and it should continue annually. The advantage of this annual screening is the greatest breast cancer mortality reduction. The diagnosis can be made at an earlier stage, better surgical options and better treatment options in the term of chemotherapy, radiotherapy can be offered to the patient. The screening program should continue past the age of 74. No upper age limit is defined by American College of Radiology guidelines. However, if there are severe comorbidities that limit the life expectancy, then we can decide the limit of just screening, when the screening should be stopped. While performing the screening mammograms every year, it must come into your mind regarding the radiation hazard, which I have addressed already, or if there are multiple biopsies performed on benign lesions, or the lesions biopsies turned out to be not malignant, some just in benign inflammation, there is risk of anxiety and overdiagnosis. But all of these disadvantages and risk, they are just outweighed by the benefit if we detect a cancer at an earlier stage by performing the screening mammograms. Now, if we see the women who are at high risk of developing breast cancer, I will explain who are the high risk patients for breast cancer. The screening guidelines say they should get a breast MRI and mammogram every year, typically starting at the age of 30 years. So the mammogram and MRI screening for high risk patients is starting at the age of 30, as compared to the average risk patients, from where the age 40 was the cutoff for starting the annual mammogram screening. The high risk patients, if we see by definition, are those who have a lifetime risk of breast cancer of about 20 to 25% or greater, and this is based basically on their family history. Or patients have a known BRCA1 or BRCA2 gene mutations. They had their genetic testing done from somewhere. Or patients having a first degree relative parent, brother, sister, child with gene mutations, and themselves have not had genetic testing done. Also, the patients females having radiation therapy to the chest when they were between age 10 and 30 years, they are high risk. And having certain syndromes like Cowden and etc. These all patients are under the umbrella of high risk patients, and they should get MRI, breasts, and annual mammogram starting at the age of 30 years. So when we talk about the screening or method of detection, we think of three things. There is mammography, clinical examination by a doctor or nurse, or breast self-examination. Self-examination is by a female herself, starting at the age of 20 to 40 years. After every menstrual cycle, it is recommended that one should perform breast examination. And if by herself she found any abnormality, she should consult a doctor. Then there is clinical examination by a doctor or a trained nurse. It is must for women over 40 annually, at least every 3 years for women between 20 to 40 years of age. And if patient or the female falls in high risk umbrella, then the clinical examination by a doctor or nurse should be performed more frequently. This is the key tool to breast cancer screening, mammogram. Mammography uses a low-dose X-ray system to examine the breasts. Mammography can show changes in the breasts up to 2 years before a physician can actually feel them. That is why annual mammography screening is advised. Mammography allows for efficient diagnosis of breast cancer at an earlier stage. While performing the mammogram, we categorize the breast or the abnormalities in BI-RADS categorization. The BI-RADS categories are divided from 0 to 6. In our setup, BI-RADS 0 does not literally exist, because in Western countries, they are just performing screening mammograms. If they found anything on that screening mammogram, they categorize it as BI-RADS 0, and they call the patient back for additional views or ultrasound correlation. In our setup, all the mammograms we are performing, they are literally diagnostic mammograms, even if they are performed for the purpose of screening. We review mammogram there and then, and if we find something, we order additional views or ultrasound correlation there and then. We do not recall the patient from home. So BI-RADS category 0, it is non-existent for us. We categorize the patients from BI-RADS 1 to 6. 1 and 2, these are totally benign categories. And the patient falling in 1 and 2 categories, they can continue their annual screening as per protocol. If there is a abnormality in mammogram, which we categorize as BI-RADS 3, which is probably benign, but what we mean is that patient should have a follow-up after 6 months. Appearances are of benign etiology, but there is subtle chance that it can turn out to be something malignant. So after 6 months, the patient is recalled for mammogram, and we upgrade or downgrade the pathology either into BI-RADS 2. They go back to their annual screening protocol, or we upstage the BI-RADS category. We categorize it as BI-RADS 4 or 5 so that histopathology correlation should be advised. For the BI-RADS category 4 lesions, 4 is divided into further 3 categories: 4A, 4B, 4C, depending upon the suspicion of malignancy. For 4A, the suspicion of malignancy is quite low, 2 to 9%. For 4B, the suspicion is 10 to 49%, while for 4C, it's 50 to 49%. For 4A and 4B lesion, the biopsy decision basically relies on the physician's judgment, family history, what the patient wants. But for 4C, they should undergo a biopsy. If a lesion is BI-RADS 4C, biopsy should be considered, or histopathological correlations. For the BI-RADS 5 lesion, they are more than 95% suggestive of malignancy. So a lesion BI-RADS 5, whatever the size is, histopathological correlation is advised, and 6 is already biopsy proven malignancy. Here, I would like to appreciate the efforts of Maroof Healthcare Services for creating the breast cancer awareness by mass campaigns. The radiology department of Maroof is also offering its all services for breast cancer diagnosis in the form of X-ray mammography and sonomammography. And I would like to share that we have extended our services. And now we are offering ultrasound guided FNACs of breast, ultrasound guided FNAC of axilla, ultrasound guided core biopsies of breast and axilla, breast clip placements, wire localizations, and ultrasound guided breast aspirations. Future directions, we are just working if we can initiate the stereotactic biopsies as well if we see any suspicious microcalcifications which are not visible on ultrasound, so that we can offer that services for our patients too. So breast cancer can be cured if diagnosed early. This is the clear message from the presentation. While taking the opportunity, I would like to share with all of you that apart from breast lesions, we are also offering following services to our patients, which include ultrasound guided FNACs of thyroid, lymph nodes, ultrasound guided core biopsies of solid viscera, liver, kidney, omentum, lymph nodes, percutaneous pigtail drain placements, whether it is ascitic pleural abscesses, and ultrasound guided aspirations, ascitic pleural. We are also offering now permacatheter insertion, temporary dialysis catheter insertions, PICC lines, and percutaneous nephrostomy insertions. I'm looking forward to cooperation from all of you. Thank you so much for your attention.